Tardive dyskinesia, or TD, and drug-induced Parkinsonism, or DIP, are two clinically distinct drug-induced movement disorders that are associated with exposure to dopamine receptor blocking agents, or DRBAs. DRBAs can include antipsychotic medications, as well as gastrointestinal medications such as metoclopramide. Both movement disorders involve abnormal, involuntary movements that can impair daily activities of living and lead to stigmas that may result in lower quality of life and reduced functioning. Although they are both drug induced movement disorders, TD and DIP each have their own unique pathophysiology, presentation, and guideline recommendations. So it's important that clinicians appropriately differentiate TD and DIP. Let's start by examining the signs, symptoms, and presentation of TD and DIP. TD typically manifests months to years after DRBA initiation and presents with hyperkinetic movements that are choreoathetotic in nature, appearing snake-like with repetitive non-rhythmic movements. Characteristic movements of the mouth and face include repetitive blinking, tongue protrusion, lip smacking, chewing, pouting, and opening and closing of the mouth. TD in the trunk and limbs may present as truncal rocking or swaying, piano playing finger and toe movements, hand rubbing, and foot tapping. In contrast to TD, DIP presents with hypokinetic movements that usually occur days to months after DRBA initiation. These movements include bradykinesia, jaw and extremity tremor at rest, masked facies, cogwheel rigidity, flexed posture, and shuffling gait. It is important to note that tremors, or rhythmic involuntary movements, are not a symptom of TD. Now that we have a better understanding of the clinical presentation of TD as hyperkinetic movement disorder and DIP as hypokinetic movement disorder, let's explore key pathophysiological differences and how these are integral to understanding the appropriate treatment options. TD is thought to be caused by chronic DRBA blockage of postsynaptic dopamine receptors, which results in an upregulation and hypersensitivity of dopamine receptors. This creates a hyperdopaminergic state that contributes to hyperkinetic movements and can also reduce cholinergic activity in the brain. On the other hand, DIP is a drug-induced movement disorder related to a hypodopaminergic state and is believed to be caused by blockage of dopamine receptors by DRBAs. This results in lower dopaminergic transmission compared to cholinergic transmission. Let's now discuss common treatment approaches and recommendations from the 2020 American Psychiatric Association, or APA, Guidelines for the Treatment of Schizophrenia. Historically, anticholinergics such as benztropine have been prescribed for the treatment of DIP, and even inappropriately for TD, sometimes as prophylaxis. It is important to recognize that for patients with TD, treating with anticholinergics can potentially exacerbate the hyperdopaminergic state and worsen a patient's hyperkinetic movements. Thus, anticholinergics are not recommended in TD. For patients with DIP, anticholinergics are a suggested treatment approach by the APA guidelines since they may reduce cholinergic transmission, restoring dopaminergic cholinergic balance, and decrease hypokinetic movements. A common approach to treatment of TD and DIP is adjusting the DRBA medication. In TD, reducing the DRBA dose or switching to another agent may worsen TD symptoms with some potential for improvement, although supportive evidence is limited. In DIP, reducing the DRBA dose or switching medication can improve the hypokinetic movements and are suggested per APA recommendations. In contrast to reducing the DRBA dose, increasing the DRBA dose may temporarily improve or mask TD symptoms. However, in patients with DIP, increasing the DRBA dose may trigger or worsen symptoms. Appropriate management of TD may involve decreasing dopaminergic neurotransmission by decreasing the amount of dopamine released into the synaptic cleft. Vesicular monoamine transporter type 2, or VMAT2 inhibitors, are hypothesized to work via this mechanism to counteract the hyperdopaminergic state seen in TD and reduce hyperkinetic movements. The APA guidelines recommend VMAT2 inhibitors such as valbenazine or deutetrabenazine as first-line treatments for patients with TD. Appropriate management of DIP can utilize anticholinergic medications as well as switching or reducing the dose of DRBA medication. While both TD and DIP are associated with DRBA exposure, they are two distinct movement disorders with unique presentations, pathophysiology, and treatment options. Therefore, proper differential diagnosis is essential to ensuring patients receive the most appropriate treatment tailored to their respective needs.